Welcome back to the deep dive. Now, usually we take a pretty broad look at a topic, maybe something trending in the news, a new piece of tech, or a historical mystery. But today we are shifting gears completely. We are going into full exam mode.
That's right. We're simulating a very specific high-pressure environment today.
Imagine the scene. It is late. The library is empty. The coffee pot has been drained dry. You can hear the hum of the fluorescent lights. And looming on the horizon, maybe a week away, maybe tomorrow, are the Gujarat University MD Anesthesiology exams.
It's a rite of passage. And a terrifying one. The stakes are incredibly high.
Exactly. So for this deep dive, you're not just an expert. You're stepping into the shoes of this senior faculty member. You're the mentor, the examiner who's heard every wrong answer in the book and knows exactly what separates a pass from a distinction.
And you're the postgraduate student.
That's me. I've got my stack of textbooks, K.D. Tripathi for the basics, Miller and Morgan for the anesthesia side, Harrison's for the medicine, and I need to turn this mountain of data into a gold medal answer.
I like it. We're going to do a structured revision session, and we're drilling down on a topic that's a classic wolf in sheep's clothing. It looks simple, but it's an absolute minefield if you don't know the nuance.
We are talking about statins.
HMG-CoA reductase inhibitors, the bread and butter of cardiovascular medicine.
See, that's the trap right there. Most of us think of them as just those cholesterol pills that half our patients are on. But for the anesthetist, and specifically for this exam, they represent something much bigger, don't they?
Oh, much bigger. If you walk into your Viva and treat statins as just lipid-lowering drugs, you will likely fail.
Really? That harsh?
That harsh. Or at best, you'll scrape a bare pass. We need to get you to the distinction level.
The mission is clear. Convert book knowledge into a structured 20-mark answer and bulletproof responses for the Viva. So, let's start where the exam paper starts. The introduction. How do I frame this to grab the examiner's attention immediately?
Okay, you need a hook. You start with a precise definition. Of course, statins are competitive inhibitors of 3-hydroxy-3-methylglutaryl coenzyme A reductase.
HMG-CoA reductase.
Right. You have to say the full name once, but then you pivot immediately to the anesthetic relevance.
So I shouldn't just talk about preventing heart attacks in 10 years.
No, absolutely not. You need to state up front. For the anesthetist, statins are about plaque stabilization and perioperative cardioprotection. We aren't just fixing a lab sheet. We are preventing a plaque rupture on the induction table. That is your opening statement.
That changes the perspective instantly. It moves it from preventive medicine to acute perioperative care.
Exactly. You have to realize dyslipidemia isn't just a number on a page. It means your patient has vascular pathology. And when we subject them to the stress of surgery, catecholamine surges, inflammation, that pathology becomes a ticking time bomb.
And statins are the diffusing kit.
That's the perfect analogy. They are the diffusing kit.
Okay, I have my opening. Now, typically, an exam question will ask for a long note on pharmacology, which means I need to nail the basic science, the physiology.
This is the foundation. If you don't understand the mevalonate pathway, you can't explain the drug. It's as simple as that.
I always get tangled in the biochemistry here. It feels like a soup of enzymes and coenzymes.
Let's simplify it. Seriously, you just need to visualize a production line. The liver is the factory, and it synthesizes about, 50% of our endogenous cholesterol? It starts with acetyl-CoA.
The universal building block.
Right. So you take 2 moles of acetyl-CoA, they condense, and you get acetyl-CoA.
Okay.
Then you add a third acetyl-CoA, and that's when you get the big molecule. HMG-CoA, beta-hydroxy, beta-methylglutaryl-CoA.
Okay, so far so good. We're just building up a carbon chain.
Now comes the most important part, the rate-limiting step, the bottleneck in the whole process.
This is where the magic happens.
This is where the drug works. The enzyme HMG-CoA reductase uses NADPH to convert HMG-CoA into mevalonate.
And this is the point of no return.
Precisely. Once you have mevalonate, the cell is committed. It's going to make cholesterol. Mevalonate eventually becomes isoprenoid units, then squalene, and finally cholesterol, a big 27-carbon molecule.
And statins hit that specific bottleneck. They just block the reductase.
Yes. But here's a detail that separates the novice from the expert. A little pearl for you. HMG-CoA reductase activity follows a circadian rhythm. Do you know when it peaks?
I've heard at night, which is why we dose some statins at bedtime.
Correct. It peaks at midnight. This is crucial for the pharmacology section later. If you're using a short-acting statin, like simvastatin, you have to hit that midnight peak. If you give it in the morning, the enzyme has already done most of its work for the day.
That is a great clinical correlate to the physiology.
Yeah.
Okay, so I've drawn the pathway, I've blocked the enzyme. Now comes the mechanism of action. Obviously, inhibit enzyme is part one. But I've heard you say there is a real mechanism that gets the extra marks.
This is what I call Viva Gold. Imagine the external examiner looks at you over his glasses and asks, "Doctor, if we just stop synthesis, why does serum cholesterol drop by 50%? Couldn't the liver just, import more from the diet, or couldn't the levels just stabilize?"
That is a very good question. Yeah, blocking production doesn't necessarily mean clearing what's already in the blood, so what is actually happening?
It's the SREBP pathway. You have to say this. Sterile regulatory element binding proteins.
That sounds incredibly complex. Break it down for me.
Think of the liver cell, the hepatocyte, as a factory. When you give a statin, you block its internal production line. So the level of cholesterol inside the cell drops.
Okay.
The cell senses this. It's like a starvation signal.
It panics. We are running out of raw materials.
Exactly. This panic, this low intracellular sterol level, triggers the SREBP. It's a protein that travels to the nucleus and binds to the DNA.
It's a transcription factor.
It is. It essentially screams at the nucleus, "We need more cholesterol. Build more vacuum cleaners."
Vacuum cleaners?
LDL receptors. The hepatocyte starts sprouting thousands and thousands of new LDL receptors on its surface.
Ah, I see. So because it can't make its own cholesterol, it has to scavenge it from the blood.
Perfectly put. It sucks LDL and IDL, which is its precursor, right out of the plasma to refill its internal stores. That active clearance, that vacuuming, is the primary reason for the massive drop in serum LDL.
That is a fantastic distinction. So it's not just a passive drop in production. It's an active upregulation of clearance. That's the key.
Correct. And that explains the effect size. You can get a 20 to 55% reduction in LDL, depending on the dose and the specific statin.
Wow. Okay, moving on to pharmacokinetics. This can feel a bit dry, but I know anesthetists love kinetics because it dictates safety.
It's very high yield. Very high yield. For your exam, you have to focus on two things: solubility and metabolism.
Let's start with solubility. Lipophilic versus hydrophilic. Why does this matter to an anesthetist? I mean, really?
It matters for side effects massively. The lipophilic statins, think simvastatin, lovastatin, atorvastatin, they can cross biological membranes easily.
Including the blood-brain barrier.
Exactly. Which is why you get those case reports of sleep disturbances, vivid nightmares. Some people even complain of cognitive fuzziness. They get into the central nervous system.
And the hydrophilic ones.
That would be pravastatin and rosuvastatin. They are more water-loving. They need active transporters to get into the liver, which makes them more hepatoselective, and they don't cross into the brain nearly as much.
So fewer CNS side effects.
Generally, yes. That's a good rule of thumb.
Okay, rule of thumb noted. Now, metabolism. This is the danger zone, isn't it?
This is the absolute danger zone, the cytochrome P450 system, specifically CYP3A4.
The workhorse of the liver. Handles so many of our drugs.
It does. And simvastatin, lovastatin, and atorvastatin are heavily metabolized by CYP3A4. Now stop and think. The ICU, the operating room. What else do we use that hits that same enzyme?
Well, midazolam. Fentanyl to some extent.
Yes, but the real danger comes from the inhibitors, the drugs that shut down the enzyme. Think about your antibiotics.
Macrolides. Erythromycin, clarithromycin.
Perfect. Or your azole antifungals like ketoconazole. Or even some calcium channel blockers like diltiazem.
So if my patient is on, say, simvastatin, and I start them on clarithromycin for a chest infection,
you have effectively overdosed them on the statin. The metabolism grinds to a halt, the plasma levels of the statin skyrocket, and the risk of toxicity, specifically muscle toxicity, goes right through the roof.
we will get to the toxicity, but that interaction is just critical to know. Is there any statin that avoids this CYP3A4 mess?
Yes, and this is another pearl for the Viva. Rosuvastatin is metabolized by a different one, CYP2C9, and pravastatin is largely excreted unchanged by the kidneys.
So they are safer choices in patients on complex polypharmacy.
Much safer. If an examiner asks, why would you choose rosuvastatin in this complex ICU patient, your answer is, to avoid the clinically significant CYP3A4 interactions.
That's a great answer. Okay, let's move to what I think is the most critical section for an anesthetist, the pleiotropic effects.
The exam favorite.
This word comes up constantly. Pleiotropic. It sounds so fancy.
It comes from the Greek pleion, which means more, and trepein, which means to turn. So it literally means many ways. In pharmacology, it just means the drug has effects beyond its primary intended target.
So we treat cholesterol, but we get a whole bundle of bonus features.
Crucial bonus features, absolutely crucial. If you are asked in your exam, why do we give statins in acute coronary syndromes even if the patient's cholesterol is normal, the only correct answer is pleiotropic effects.
Okay, let's list them. What are the key non-lipid benefits that an anesthetist really cares about?
Number one, without a doubt, endothelial function. Statins increase the bioavailability of nitric oxide.
The body's own natural vasodilator.
Yes, it keeps the vessels healthy, relaxed, less sticky. Second, and this is maybe even more important for us, plaque stabilization.
How does that actually work? Does it shrink the plaque or
Well,
harden it?
it doesn't really shrink it, no. It remodels it. It reduces the inflammation inside the plaque. It stops macrophages from chewing away at the plaque's fibrous cap. It actually makes that cap thicker and stronger.
So it's like putting super glue on a cracked wall. It prevents the plaque from rupturing under stress.
That is a perfect way to think about it. Surgery is a massive stress test. You get high blood pressure, tachycardia, sheer stress on the vessel walls.
Oh.
If you have a vulnerable, inflamed plaque, it can crack open, form a clot right there, and cause a perioperative MI.
And the statin prevents the crack.
The statin reinforces the wall. It keeps the plaque stable.
That makes so much sense.
Yeah.
What else is in this pleiotropic package?
You have anti-inflammatory effects. They lower systemic inflammatory markers like CRP, IL-6, and TNF-alpha.
Right.
And you have antithrombotic effects. They reduce platelet aggregation and thrombus formation.
So it's almost like you're getting a mild aspirin plus an anti-inflammatory plus a vasodilator all in one pill.
Exactly. And the best part is these effects happen fast. We're talking within days or weeks, not years. That is why they provide such powerful protection against the massive stress response of surgery, or cardiopulmonary bypass, or aortic cross-clamping.
Okay, so we've established that these drugs are, frankly, wonder workers for the vasculature. Now let's get into the clinical meat. Statins in anesthesia and perioperative medicine. This has to be the highest yield topic of all.
This is the pass-fail question.
The to-stop or not-to-stop question.
This is where students fail. Let's be very, very clear. What do the SUAHU guidelines say?
Class, I recommendation. Continue statins in patients currently taking them.
Correct. Do not stop. Ever.
Even if they are MBM, the surgeon says strictly nil by mouth from midnight.
I don't care what the surgeon says. Give it with a sip of water. If you absolutely can't for some reason, make sure it's in the post-op orders to be given immediately. Put it down the nasogastric tube if you have to. Just get it in.
Why are we so adamant about this? What really happens if we skip a dose or two before a big case?
The rebound phenomenon. This is a critical concept you must explain.
What is rebound? Is it just the cholesterol coming back up?
It's so much worse than that. When you withdraw statins suddenly, you don't just go back to your baseline risk. You get a spike. A rebound increase in inflammatory cytokines. The endothelium becomes dysfunctional again. The blood becomes prothrombotic. All those beautiful pleiotropic effects vanish, and you get the opposite.
So you are removing the brake from the inflammatory cascade right when the patient is undergoing the biggest inflammatory stress of their life surgery.
Exactly. It creates a perfect storm for a perioperative heart attack. The evidence on this is overwhelming. Perioperative statin use reduces 30-day mortality. Some studies say by up to 44% in major non-cardiac surgery.
44%. That is a massive number. That's not a subtle effect.
It is huge. It reduces MI, it reduces stroke. Stopping the drug is, quite frankly, malpractice in the modern era. It's indefensible.
Okay. What about starting them? Say I have a vascular patient coming in for a femoral popliteal bypass, and for whatever reason, they aren't on a statin. Do I start it the morning of surgery?
That's a good question, a bit more nuanced. The guidelines class, though, say it is reasonable to initiate statins in vascular surgery patients, but ideally you want to start at least 2 weeks pre-op, maybe even 4.
Why the 2-week lead time?
You need time to get those pleiotropic effects on board. Plaque stabilization doesn't happen overnight. Also, you want to avoid any acute side effects like myalgia during the critical induction period. The POISE trial showed that starting high-dose statins on the day of surgery in naive patients actually didn't help and might have caused some issues, so load them early if you can.
And what about in cardiac surgery? Bypass grafting, valve replacements.
Highly beneficial. They've been shown to reduce the systemic inflammatory response syndrome, or SIRS, that you see with cardiopulmonary bypass. They also reduce the incidence of postoperative atrial fibrillation, POAF, which is a huge problem.
Yeah. Okay, so the verdict is crystal clear. Keep them going. If they aren't on them, consider starting early for high-risk cases. But, as they say, nothing in medicine is free.
Right.
We have to talk about adverse effects.
The exam core topic, the big one everyone knows, is muscle toxicity. But just writing muscle pain isn't a sufficient answer for an MD exam. You need to describe the spectrum.
Walk me through the spectrum.
Okay, at the mildest end, you have myalgia. This is just muscle ache or weakness. The patient complains of soreness, but their enzymes are normal. It's common, often benign.
And the next step up.
Myositis. This is muscle symptoms plus an elevated creatine kinase, or CK. Now you have biochemical evidence of muscle inflammation.
And finally, the disaster scenario.
Rhabdomyolysis.
The nightmare everyone is scared of.
It's the most severe form. You have massive muscle breakdown. CK levels go into the thousands or tens of thousands. This releases myoglobin into the blood, which clogs up the kidneys, giving you myoglobinuria, the famous tea-colored urine.
Which leads to acute renal failure.
Acute renal failure, hyperkalemia, metabolic acidosis. It's a full-blown medical emergency.
So what are the risk factors? Who is most likely to get rhabdo?
High doses, obviously. Being elderly. Having hypothyroidism, always check the thyroid function if someone develops myopathy. Pre-existing renal failure. And importantly, those drug interactions we discussed. A patient on simvastatin plus clarithromycin plus cyclosporine is a rhabdo case just waiting to happen.
Right. Okay, what about the liver? We are always taught to treat LFTs.
Hepatotoxicity. Yes, you can see elevated transaminases, the ALT and AST. It's usually dose-dependent, and in most cases, it's reversible when you stop the drug.
There is a trap here, though, isn't there? If a patient comes in for elective surgery and their pre-op ALT is 70 when normal is below 40, do we cancel the case?
This is a classic Viva trap, and the answer is usually no. Mild elevations, say up to 3 times the upper limit of normal, are common and often benign. Unless the patient is jaundiced or there are signs of actual liver failure, like a high bilirubin or coagulopathy, you usually proceed with the surgery.
Right. Don't cancel a critical surgery for a slightly bumped enzyme number. There's probably just the statin doing its thing.
Exactly. Context is everything.
What about the diabetes link? I've seen headlines about statins causing diabetes.
Yes. There is a small but statistically significant increased risk of new-onset type 2 diabetes. The mechanism seems to involve a slight increase in insulin resistance. But the consensus from every major cardiology society is overwhelming. The cardiovascular benefit of preventing a massive heart attack or stroke vastly outweighs the small risk of slightly higher blood sugar down the line.
The benefit-to-risk ratio is huge.
It's not even close.
Okay. Let's zoom back in on drug interactions, but specifically the ones that can kill a patient in the OR or ICU. We hammered CYP3A4 inhibitors. What about succinylcholine?
This is a beautiful theoretical risk that examiners love to ask about. It tests your ability to connect concepts. So if a patient has active severe rhabdomyolysis, what's happening to their electrolytes?
Well, their muscle cells are breaking open, so all the intracellular contents are spilling out. That means a lot of potassium. They're hyperkalemic.
They are hyperkalemic. And succinylcholine is a decolorizing muscle relaxant. What does it do to potassium?
It also causes a small, transient release of potassium, usually about 0.5 milliequivalents.
Exactly. So if you give succinylcholine to a patient who is already hyperkalemic from rhabdo, you could push their potassium into the lethal range and cause a cardiac arrest.
So if a patient comes in with a crush injury or has dark urine and muscle pain suggesting statin myopathy, succinylcholine is off the table.
Absolutely off the table. Use rocuronium. It's a non-depolarizer. It's safe.
What about warfarin? We still see a few patients on warfarin.
It's a less dramatic interaction, but statins can potentiate the anticoagulant effect of warfarin. You might see the INR drift up. It's just something you need to be aware of and monitor.
Okay, we're in the home stretch now. We need to cover contraindications. When can you absolutely not give a statin?
Okay. The absolute contraindications are pretty straightforward.
Yeah?
Active liver disease, and by that I mean unexplained persistent enzyme elevation or signs of actual liver failure, not just a stable, slightly high ALT.
Right. And the other big one.
Pregnancy and lactation.
What pregnancy?
Because cholesterol is absolutely essential for fetal development. It's the building block for cell membranes, steroid hormones. You cannot block the building blocks of a developing fetus. It is category X. Absolutely forbidden.
Got it. Okay, now let's do the Viva traps. Let's role play this.
Yeah.
I am the external examiner. I'm looking over my glasses at you, looking tired and unimpressed.
I'm ready. Go for it.
Doctor, my patient is scheduled for a bowel resection tomorrow morning. He is nil by mouth from midnight. Should I skip his atorvastatin this morning to keep his stomach empty?
No, sir. Per the class ICCA guidelines, I would administer the atorvastatin with a small sip of water. The half-life of its pleiotropic effects, particularly plaque stabilization, is short, and sudden withdrawal can lead to a rebound pro-inflammatory and prothrombotic state, significantly increasing the risk of a perioperative myocardial infarction.
Good. Very good. Trap number 2. Are statins just for lowering lipids? This vascular patient is on a high dose, but his cholesterol is already normal. Why bother?
No, sir. In this patient, the statin is being used primarily for its significant pleiotropic effects. These non-lipid-lowering benefits, including endothelial protection, systemic anti-inflammatory properties, and most importantly, atherosclerotic plaque stabilization, are crucial for perioperative cardioprotection, regardless of the patient's baseline lipid levels.
You hit the keyword, pleiotropic.
You have to. It's the magic word.
Final trap. A trauma patient comes in. Massive car accident. Crush injuries to both legs. You see he's on high-dose rosuvastatin at home. Any specific concerns?
Yes, sir. I would be hypervigilant for the development of rhabdomyolysis. Both the significant muscle trauma from the accident and the underlying statin therapy put the muscle at high risk of breakdown. I would immediately order a serum CK and urine myoglobin, ensure aggressive intravenous hydration for renal protection, and monitor his potassium and renal function very closely.
Brilliant. You've passed.
Yeah.
Now let's visualize the written paper. The long answer. You can't just write a wall of text. You need diagrams. How do I visually represent this to get full marks?
Okay, you need 3 simple, clean diagrams in your head. Diagram 1 is the mevalonate pathway, a simple vertical flowchart. Acetyl-CoA at the top, arrow down to HMG-CoA, then a big red X or a block labeled statin, blocking the arrow that points to mevalonate. Simple, effective.
Okay, that's easy enough.
Diagram 2 is the LDL receptor cycle. Draw a big square for the hepatocyte. Inside it, draw a circle for the nucleus. Show an arrow coming from the nucleus to the cell membrane where it creates a Y shape, that's your LDL receptor. Then draw a little circle outside the cell, the LDL particle, being caught by the receptor. You must label an arrow pointing to the receptor and write upregulation via SREBP due to low intracellular cholesterol.
That shows the entire real mechanism perfectly.
It does. And finally, diagram 3 is the pleiotropic sun, or a spider diagram, whatever you want to call it. Put statin in a circle in the center, then draw arrows radiating out from it like the sun's rays. At the end of each ray, write one of the key effects: improved endothelial function, increased NO, plaque stabilization, decreased platelet aggregation, anti-inflammatory, decreased CRP.
That covers all the bonus features in one glance. The examiner sees that and knows immediately you get the big picture.
Presentation matters. And structure your long answer illogically. Introduction, classification, if you want, mechanism, pharmacokinetics, pleiotropic effects, anesthetic implications, adverse effects, drug interactions, conclusion.
So, let's wrap this entire session up with a final summary and exam conclusion. Give me the bullet points I need to have tattooed on my brain right now.
Okay, here we go. High-yield recap. 1. Statins competitively inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. 2. They lower serum cholesterol mainly by upregulating hepatic LDL receptors. You must mention the SREBP pathway. 3. The pleiotropic effects are the secret sauce for perioperative safety. It's about inflammation and plaque, not just lipids. 4. Never ever stop statins perioperatively. You have to explain the rebound phenomenon. 5. And finally, watch for myopathy, know your risk factors, and know your CYK3A4 interactions like the back of your hand.
And then the model conclusion paragraph, the one I write at the very end of the 20-mark paper to just seal the deal.
Listen close. Memorize the structure of this. In conclusion, statins are not merely lipid-lowering agents, but are, in fact, potent vasculoprotective drugs with significant and rapid-acting pleiotropic properties. Their uninterrupted continuation in the perioperative period is a Class I recommendation, essential for reducing cardiovascular morbidity and mortality. The vigilant anesthesiologist must appreciate their role in plaque stabilization while remaining mindful of their potential for myopathy and critical drug interactions, thereby ensuring uninterrupted therapy to prevent rebound endothelial dysfunction and adverse cardiovascular events.
That sounds like a gold medal answer to me.
It connects the basic science to the clinical practice, and it uses the right terminology. That is exactly what the Gujarat University examiners, and frankly, any examiners, are looking for.
Thank you, Professor.
Yeah.
I genuinely feel ready to face the board. I can see the pathway, I can explain the rebound, and I definitely will not stop the drug.
Just remember when you're in there. Visualize that plaque stabilization. It's happening right now, in real time, in your patients. You are the guardian of that plaque during the stress of surgery.
And to our listener, if you're prepping for your MD or just brushing up for your own practice, remember this. Knowing the why, the pleiotropic effects, the mechanics of the rebound, is what separates a good, safe anesthetist from a truly expert one.
Good luck. Go ace that paper.
We'll see you on the next deep dive.